Okay, so if you have any questions today, please do pop them in the box. They could be here in the Click Meeting room, or they can be on Facebook as well. Please do bear in mind that we're not here today to provide specific medical advice, but we're here to give general medical information. And hopefully what we're trying to do is empower you so that in your next consultation, in your next medical appointment, that you feel better empowered and better able to ask the questions you need of your own consultant in your own circumstances because of the general information that we've given. So hopefully that sounds fair and reasonable. So James, coming to you as a man who's made many mistakes. The
and
question
very
is,
few of them.
The question is in and around painkillers. So we know that there's not one answer to painkillers and PBC, but what can you tell us in general terms? And because we have time, it'd be nice to have as comprehensive an answer as possible, please, because this is something that comes up often. And I know, we've worked together for years. I know, for years you've looked at the patient holistically and not just where they are at that moment in time. So can you maybe talk to us about painkillers and PBC in general terms?
Thanks. I think there are two things. The first is with pain is to try and identify the cause of the pain. And there are many, many causes, and that's a separate issue. And I think we may come back to that, but I'll leave that for the moment. So why have you got pain? Very often it's obvious. You fell over, you broke your wrist. Okay, that's fairly obvious. If it's not obvious, if it's something particularly non-specific, like tummy pain, again, it's much more difficult to know, is it serious, is it not? When I say serious, I mean, is the cause something that's serious, or is it something that's trivial? So you really want to know what the cause of the pain is. If it's obvious, that's fine. If it's not obvious, then if it gets worse, if it persists, then you need to have that investigated. The second point I want to make is that the response to pain is very variable. And it's very much dependent on obviously the cause of the pain, but your people's reactions to pain varies enormously. And the example I was given many years ago when I was a student in the days when gaslight meant normal living rather than what it does now. The example I was given was somebody on the hockey field or on the football field, and I'm sure a player such as Robert will know this. You'll have a nice enthusiastic game of football or whatever, hockey, and you'll come away and you notice that you've got some bruising on your shins and you won't know how it got there. Somebody kicked it, somebody kicked your shins, ball particularly hard, collided with goalposts, what have you. But there's been a trauma that's resulted in bruising, and you may notice some pain, you may not. Now, if you contrast that with saying, right, let's stick with the football example, say an 18-year-old male, okay, you choose them out of the class and say, in half an hour, I'm going to kick you on the shins. And it's 5 minutes to go now, so stand up on the desk and get ready for it because I'm going to kick you. And the pain you would start to feel the pain, I suspect, even before you were kicked. And that was quite a good example for me in my sporting days, believe it or not, they were there, of how subjective aspects can affect how you perceive pain. And again, we see that all the time with people, say, undergoing surgery, where the stimulus is the same, but people's responses are very variable, and many factors go into that. The second point I'd make about pain is only the person know whether they have pain or not. It's no good, we can argue whether somebody's jaundiced or has got ascites, but what we can't argue with is whether you've got pain. There's no objective assessment of pain. You know if you've got it, and if you say you've got it, then people have to believe it and act on it. So it's variable, it's subjective, and that's not to denigrate it. But and for example, if you're depressed, if you're anxious, if you're stressed, then the same pain will seem a lot worse, and that again is natural and understandable. There are measures of pain, and when people go into hospital, say for, to look at post-operative pain, there are scales, and you're also rated on usually 1 to 10. That gives you some guide, but again, what really is, I think, as a healthcare professional, you're looking for the changes of the pain, because your 6 and my 6 may be different. So it's difficult to measure because it's subjective, but that is not to say that it's something that should be taken very seriously, irrespective of the cause. And there is no correlation really between the severity of the pain you have and the severity of the cause. So, for example, I don't know, cancers are often painless, and trauma is something that's happened, no damage has been done, you're in pain, and it'll get better. So it needs to be taken seriously if it's affecting your life. I think sometimes people have an unrealistic approach to pain and to expect to be pain-free. Ideally, yes, but sometimes it's worth putting up with a background of mild pain. But that's up to the individual to decide how much is tolerable, how much it interferes with their life, how much they want to have interventions. When it comes to treatment of pain, again, it's very important to remember that pharmacology, drugs, is only one possible treatment. Psychological support, cognitive, is again a useful adjunct. Some people naturally and sensibly are worried that they have pain and there's something serious going on. And if you can allay those symptoms, that makes sometimes the pain less severe. Sometimes cognitive behavioral therapy or alternative treatments, ways you can learn to deal with the pain so that you can lead a normal and fulfilling life. I don't think that applies to an awful lot of people, but again, it's one thing to think about. Another thing I would say is don't underestimate the role of physiotherapists. They have a huge potential. They have great knowledge. I think in the NHS, certainly, they're often undervalued and underused and overworked. But they do have a lot of knowledge, a lot of experience and techniques to deal with pain and to know which one is likely to work. Particularly, I'm thinking of soft tissue injuries, sports pain, and those sort of things, but also the pain of arthritis, of rheumatoid, and so on. Don't underestimate what they can offer. They will also offer, in some cases, exercises, I should say, to strengthen the muscles, and that in some cases will again help support the joints or other tissues and enable you to live with the problem more effectively. So physiotherapists have a lot of different treatment options available, like ultrasound, hot wax and so on, and they have expertise in knowing what is likely to work. So consider those experts. They may be appropriate to give you advice and even treatment. Other forms of treatment certainly can work. Acupuncture, I was quite skeptical about acupuncture, I have to say, but there have been a number of studies now showing that it does work in some people. And the studies that are more convincing to me were those with sham acupuncture. So this was done either with, this was done using needles, if you like, in the wrong place or the wrong needles, and showed that people who had acupuncture delivered by acupuncturists had much better pain relief. So it may work for you. And I've read, I'm sure other people have too, of the experiments of people having childbirth under acupuncture, and I think it does work for some people.
Okay, perfect, thank you. And in terms of Western medicine, sorry, on you go.
Oh, yes. So coming back to pharmacological treatment, again, that has a place. And the key thing, I think, about all treatments, whether psychological, physical, whatever, is different painkillers work for different people at different times. And it's a matter of seeing what works for you. I said earlier on, and I'm sure people agree, that pain is very subjective. You know what pain you've got, you know how it affects you, and you'll know then whether treatment is working. Yes, for pain relief, as in any other treatments, there is a placebo effect. We see that in numerous trials, that people get side effects from placebo. But again, if it relieves the pain, whether it's a placebo effect or not, does it matter? The answer is no.
Yeah.
So what do you use in terms of pain relief? Now, essentially, there are two ways you can deliver pain relief. Well, three, I suppose. One is topically. That means you apply it to the skin. And that can work. There are two types of if you like, broadly two preparation types. One is the gels that you can buy. Ibuprofen gel is a classic one, or I believe anisole again is another topical pain relief for piles. You apply it topically, and it does in some cases help. The theoretical advantage of topical treatments is you can apply them more frequently, and you don't absorb the active ingredient to such a significant extent. You can get, for example, we use these a lot in people with severe pain, patches. Again, the active compound, often something like morphine, is applied on the patch that's put on the skin, and it gradually gets dissolved through the skin and works. It has many advantages. It's easy to take. You can apply it, but absorption is variable. Some people have thicker skin than others. It depends where you put it on and so on. But that's another way that works for some people. There's intravenous pain relief, such as you might have following an operation or for other reasons. And then there's oral medication, and oral medication, there are various preparations. You can take them, they can dissolve in the mouth, often under the tongue. You can take them as tablets, you can take them as capsules. There are some differences in price. There are also differences in speed of onset. Now, really, you have a hierarchy of pain relief, and usual thing is to start with the simple analgesics. In most cases, obviously, if you've had a hip replacement or major abdominal surgery, then you're not going to start with paracetamol. Although, again, going back to my days doing obstetrics, I was absolutely staggered that people who had had childbirth was just given peppermint water. I'm surprised nobody threw it back in the midwife's face, but anyway, that was what they did then. Paracetamol and the so-called NSAIDs, non-steroidal anti-inflammatory, are the two entry-level drugs. Paracetamol is good and safe. It does have a slightly bad name, particularly with liver conditions, because an overdose of paracetamol can lead to liver failure. So if you're taking paracetamol, you want to limit to probably 6 or at the most 8 tablets of 500 milligrams a day and take no more than that. Paracetamol is usually well tolerated, and if it works, that's great. But I often prescribe medication, and do remember it doesn't work in the bottle. You have to take it by mouth. And it's surprising how many people are prescribed analgesics and don't take them. But take them, if you're going to take them regularly, take them as needed, and take them before the pain gets too bad. You know the pain, you'll know how it affects you. And if you know the pain's going to come and get worse, sooner is better than later. It's usually easier to prevent pain getting worse than to treat bad pain. Now, the other group of drugs are the so-called non-steroidals, of which brufen, ibuprofen, Nurofen and aspirin indeed are the classic ones, but there are many Me Too type drugs. They have to be used with caution in people with liver disease from any cause. They can be very effective, but people with liver problems are more susceptible to the side effects of non-steroidals, particularly for gastric irritation, and your doctor may suggest you take a drug such as omeprazole or esomeprazole as well to reduce the gastric irritation risk. But they can also damage your kidneys, and too much non-steroidals, particularly in those with liver disease, can cause renal damage, and that can either be acute or it can be long-term. And we do see what's called analgesic nephropathy in people, not just with liver disease. So if you are taking medication, so be careful if you're taking non-steroidals, and it's probably best to ask your doctor, how safe is it for you? Often if you have very early PBC, then it's probably reasonable. If you have late PBC or other liver disease, it's more hazardous. But talk to your doctor and get their steer so you know for the future. Paracetamol and non-steroidals can work together. They act differently, so you can take both at the same time. But I slightly worry as to people doing that because the pain must be quite severe for that. Another drug that people often give for chronic pain is something called amitriptyline. Now, this is a drug that was used primarily for antidepressants, and it was quite an effective one, but we have much better ones now. But at low dose, I'm talking about 25 milligrams a day, that sort of dose, you'd give 250, 500 for depression. For low dose, they do act helping the effect of the analgesics. So if you've got ongoing pain, sometimes amitriptyline can help. It's not to treat a depression. It's not saying you're depressed, although long-term pain can make you depressed, but the amitriptyline is there to help the pain relief work, not to treat any depression. If there is depression, that's something different, and you need to treat that and treat it properly. And whether you do it by CBT, behavioral therapy, medication, or combination is to discuss with your doctor. If those don't work, then again, there are other drugs that you can give to help relieve the background pain, and your doctor will discuss that with you. Then really, for most people, you're going on to the morphine type drugs, the opiates, and that's quite a big step up. They do work very well for some people. They are very good pain relief medication. There's the major concern of addiction and dependence, and we've seen in the States the horrific consequences of that. So in the short term, that's not a huge problem, although it's a worry, but in the long term, it's something you clearly have to guard against. And when you're going to those levels of drugs, opiate dependence is a very big worry. They do have other side effects. They're quite good at constipating you. And particularly if you've got advanced liver disease, that's bad news. You need to avoid that. They can make hepatic encephalopathy worse. They can also have numerous other side effects. But those sort of opiate drugs have to be given by prescription, and your doctors will, I hope, go through the pros and cons with you and adjust to your case. So if you are going to have analgesia, start simple ones, paracetamol. Topical non-steroidals are probably okay. If you're having, if paracetamol doesn't work, talk to your hepatologist or nurse or doctor and see whether non-steroidals are appropriate for you. Look at other physical measures, heat, physio, whatever, to see if they will complement, not replace. And I would finally say, sorry to the end, is that pain doesn't ennoble the soul. It doesn't make you a better person. It just makes you worse to live with and ruins your life. So take it seriously, make sure it's taken seriously. There are pain clinics, but they're huge waiting lists. But severe pain that impacts your quality of life needs to be taken seriously with a stepwise approach and adjusting it, see what works for you. And if one treatment doesn't work, try another. So it's a complex area. People are getting better at it, at understanding the implications, but it really does impact on people's lives and needs treatment.
Okay, perfect. Thank you very much. That was fantastic. Thank you.
Long, I don't know.
No, that's great, and that's brought a huge amount of detail, and I think that's a really clear, not just an answer, but a whole subset of answers. So thank you for that.